This video is designed to provide you with limited background information on pulmonary hypertension and some of the medications used to manage the disease. While the main focus of this video will be on learning to use the CADD legacy pump, determining the dwell volume, and how to prime the line, cassette changes, as well as managing the patient. Pulmonary hypertension is defined as a mean pulmonary artery pressure greater than or equal to 25 millimeters of mercury. Pulmonary hypertension can occur for various reasons, but it results in a narrowing of the arteries of the lungs. The narrowing restricts blood flow to the lungs and causes high resistance. The right ventricle must work harder to pump blood to the lungs to be oxygenated. As the right ventricle works harder, it grows and it begins to compress the left side of the heart. This results in an increase in right and left ventricular afterload, a decrease in cardiac output, and a decrease in stroke volume. There are various medications available that act on different pathways to help manage pulmonary hypertension and its symptoms. Because we are learning about the CADD legacy pump today, we will be discussing the medications we currently run using the CADD pump, specifically Epoprostenol and Hypertension, both of which are members of the prostaglandin family and therefore act on the prostacyclin pathway. Epoprostenol and Hypertension directly vasodilate pulmonary and systemic arterial vascular beds and inhibit platelet aggregation. As a result, right and left ventricular afterload are reduced, and cardiac output and stroke volume are increased. The effect is dose dependent. It has been shown to increase exercise capacity, improve hemodynamic status, and extend survival rate in patients with pulmonary artery hypertension. Epoprostenol. Both Velitri and Flolan are epoprostenol. They're just mixed with different amino acids, making it stable for different lengths of time at different temperatures. They both have a half-life of 3 to 5 minutes. For this reason, additional cassettes are to be stored in the refrigerator on the unit. Cassette changes are done daily at 11 a.m. The main difference is Flolan requires ice packs. The ice packs are scheduled in the MAR like any other medication. They are sent from pharmacy and they are scanned as any other medication would be. Hypertension, also known as Remodulin, has a half-life of 4 hours. It can be delivered intravenous or subcutaneously. The IV version cassette changes are done every 24 or 48 hours, again at the universal change time of 11 a.m. Sub-Q can be changed every 72 hours. Additional cassettes are stored in pharmacy and are ready on call. This is due to the extended half-life. Okay, now we're going to go over pump setup. So unless you're initiating the infusion, actually all the supplies should be in the patient room other than the medication cassette. The things you'll need are the CADD legacy pump, your CADD extension set with filter, AA batteries, which we change every 7 days, and that's documented in Health Connect, a coin, the patient medication cassette, and backflow cap. So in order to change the medication cassette, the first thing you're actually going to do is look at the cassette. So you'll grab the patient cassette, you'll verify the patient information, the concentration, and you'll look at the expiration date. If there's several cassettes in the refrigerator, use the cassette that expires first. So to connect the cassette to the pump, you're going to look for the 2 feet on the cassette, and those will latch over the 2 small bars on the actual pump, and then the cassette just pops right into place. While you hold it together, you're going to take your coin and push down and turn counterclockwise. This locks the cassette onto the pump. When the notch is in line with the seam of the pump, the cassette should be locked into place. Once that is done, you're going to grab your extension set and you'll open that up. There are 2 ends. So there's a blue and a white end. The filter is closest to the white end, and that is going to connect to the patient. So this is going to go closest to the patient. So the blue end you're going to connect to the cassette. So you'll take the red cap off here. You'll swab it good with alcohol. You're going to disconnect the blue cap and screw this into place. Then on the further end here, again, the filter closest to the patient's side, you're going to grab your backflow cap. And these are green, which is unlike any of our other caps, which is nice because it's distinctive. You'll open this guy up. You're going to pop the clear cap off and then screw this into place. And once we've set and programmed the pump and primed the line, this end will ultimately connect to the patient. Now we're ready to program the pump. So we've just connected the cassette with the extension tubing and the backflow cap together, and we're ready to program the pump and prime the line. So the first thing you're going to do is turn your pump on, hit the on-off button. The pump's going to complete a self-test. So with each screen, it will beep, and there will be 6 beeps at the end, and the final screen will read stopped. So to begin programming the pump, you're going to hit next. The first screen reads reservoir volume. You want this set to 100 mLs. So to reset it, you're going to press enter clear, and that will bring you back to 100 mLs, and then you press next. The following screen is continuous rate. So at this point, you're going to review your order in KP Health Connect and set it to the doctor's orders. Again, it's in mLs per 24 hours. For instance, if it was 45 mLs in 24 hours, you're going to use the up and down arrows to get to the set rate. So 45 mLs, 24 hours. You hit enter clear to save, and then next for the following screen. Next screen is given volume, which you want to be 0 mLs, which in this case it is. If it's not, you press enter clear to reset to 0, and then next. The air detector should always be off. So next, upstream sensor off, next, and the final screen reads stopped. At this point, you're ready to prime the line. So you're gonna press the prime button and hold it down. It will beep 3 times. And then release and press again. The screen reads priming. So you're going to hold it till the line and the cap are completely primed. You can hear the pump and you can see the medication moving through the line. But make sure you hold down the prime button long enough that a few drops of the medication come out the end. That way you know the entire line and cap have been primed. Now you're ready to review the pump settings. So you're going to press start stop, and then you're going to hold it down. It will beep 3 times. The pump's going to scroll through all the settings for you to check, and then at the end the pump will read run. If it doesn't say run, the pump is not running. So it's super important to make sure the screen reads run. Now you're ready to connect your new programmed and primed line to the patient. So there I purposely clamped the line so you could hear what the alarm sounds like. As you heard, it's not that loud. That's why the patient door needs to be open so you can hear if the pump is alarming at any time. Once the alarm is cleared, the pump should switch back over to run. Make sure the screen reads run, otherwise the medication isn't infusing. That's the most typical alarm. If the line is kinked or the patient's laying on it, as you just saw, it'll make that noise and the screen will read high pressure. Once it's resolved, again, it should switch back over to run. Just make sure the pump says run, and then you're good to go. Now I'm going to go over priming the line. So with Epoprostenol and Triprostenol, if you are initiating the infusion, you are changing lines or sites, or if the concentration change is greater than 15,000 nanograms per ml, you must prime the line. Right here we have a single lumen central access, which is the ideal access to have. That's not always the case. So again, these medications can run peripherally if they have to, or you may have a multi-lumen access. In a perfect world, though, it will be a single lumen central access, and because we have control of that today, that is what we're using. Again, the purpose of priming the line is so that when you connect the medication, the patient almost immediately begins to get the medication. If not, these medications run at very small volumes, so it can be a long period of time before actually any of the medication hits their bloodstream. This is particularly important if they've already been on the infusion and you're just switching access or sites, because if you do not prime the line, it's almost as if you've abruptly stopped the medication, and that can result in serious side effects and even death. So it's important to prime the line. Okay, so let's do the prime volume. So you just need a few things to do this. You're going to need some 3 ml syringes, saline flush, and then you'll also need your medication cassette of the patient, because it's from here we're going to withdraw the medication that we use to prime the line. So you will wash your hands appropriately, you will put on gloves. I don't have any, unfortunately, so for right now we'll just have to pretend. You're going to go to the infusion port you will use. You're going to open up your 3 ml syringe. I like to, sometimes there's some extra air, so I push down on the plunger, expel any extra air. You're going to unscrew the cap. So you want to take it down all the way to the hub of your line. Swab with alcohol. Attach your 3 ml syringe, and then you're going to start to slowly draw back on the line until just a flash of blood is seen at the top. So nice and slow, you're going to pull back till a flash of blood is seen. Looks like probably there for me. Although this is not a real patient, as you may or may not be able to tell, so it's a little difficult. So flash of blood is seen, so that is your dwell volume. Then you're just gonna scrub the hub again, and you're gonna take a saline flush. At this point, your line is just filled with blood, so you wanna flush that clear. So we're just gonna flush that. And now we're gonna determine our prime volume. So if you look here, it looks as though our dwell volume is 0.8. So that's 0.8 mLs. So we're going to take 80% of that to use as our prime volume. So in order to determine the 80%, so again, our dwell volume is 0.8 mLs. We're going to multiply that by 0.8 to get 80%, and that equals 0.64. So our prime volume is 0.64 mLs. The next thing we do is we're going to grab our patient's medication cassette. You will unscrew the red cap. You will scrub it with some alcohol. You're going to take another 3 ml syringe and attach that. And then you're going to slowly draw back your prime volume. So again, that's 0.64. So you're going to pull back. You can overshoot it because again, this isn't attached to anybody or anything at this time. Disconnect. Can put the red cap back on for now. And then you have your 0.64 mLs. So once you've drawn up that volume, it's your prime volume. It's 80% of your dwell. Again, that's so you don't bolus the patient. That's why we use 80%. So you're going to disconnect your flush. You're going to attach your prime volume. And you're going to slowly instill that into the line. Once you've done that, and you've programmed your pump and primed your pump and the line and the cap, you will take the cap at the end of your tubing here. Again, this has all been primed with the medication, so this attaches right on. And once you start your pump, the patient will begin getting the infusion almost immediately or shortly thereafter because you've already primed the line. With new line present, clean hub and prepare to aspirate dwell volume. Dwell volume is the volume of fluid in the IV, catheter, and hub. To do this, attach 3 ml syringe and slowly draw back until flash of blood is seen in syringe. This is the dwell volume. Flush line with normal saline. Now determine the prime volume of the catheter, which is 80% of the dwell volume. To determine the prime volume, take your dwell volume, which in this instance is 0.3, and multiply by 0.8 to get 80%. This is your prime volume. Okay, so we just went over how to determine the dwell and prime the line. Again, the prime volume is 80% of the dwell. So you take your dwell volume, you times it by 0.8, and that gives you your prime volume. We prime the line when we're initiating the infusion, we're changing lines, or the concentration change is more than 15,000 nanograms per ml. So here's an example of when you would reprime the line due to a concentration change. So in this example, the concentration of the cassette is going from 15,000 nanograms per ml to 45,000 nanograms per ml. So that's greater than 15,000 nanograms per ml, so you have to reprime the line. Again, the purpose of this is if you look at the middle column, the infusion rate in mLs per 24 hours is going to go from 77 down to 29. That's a drastic change in mLs per 24 hours. So if you were to not reprime the line, the patient would be underdosed for several hours until the entire line was cleared. Hamping. So these medications are all high alert medications. A true hamp is an independent double check, and it must be performed when initiating the infusion, dose changes, cassette changes, line changes, and at change of shift. Other than the traditional hamp of scanning the patient and scanning the medication and hamping via the MAR, you must also complete this IP nursing note. So if you go to IP nursing and you type in .2RN, check prostacyclin, this note will populate. If you are just doing a dose change, you only need to complete the top portion of this note, and you can delete the handoff procedure portion. So you would just complete what you see here with another RN. If it's change of shift, you must complete the full note, the hamp, as well as the handoff. Again, so if there is a dose change, you will complete the top portion, the hamp procedure portion. And at change of shift, you will complete the full note with another RN. This slide lists some of the side effects. Obviously, these aren't all of them. There is a lot, but some of the highlighted ones are the ones we often see. Hypotension. Again, these medications are severe vasodilators, so you will also often see a drop in blood pressure. Decrease in SpO2, bradycardia, headache, cyanosis, flushing, shortness of breath, jaw pain, pallor, diarrhea, chest pressure or tightness, lightheadedness, fatigue, nausea. Most of the time, these side effects are seen when up-titrating the medication. So when we up-titrate the medication, at a minimum, we're going to monitor blood pressure every 15 minutes times 2, then every 30 minutes times 2, and then every hour. Obviously, it's a nursing judgment if you need to monitor vital signs more frequently, and you can do so, but this is the minimum. Safety precautions. This is very, very important. So you never, ever flush the line with any of these medications. Even if you're switching sites, you do not, once you disconnect, flush the line. Again, that entire prime volume that we determined earlier is sitting in the line. So if you flush that line, you'll be bolusing the patient with that medication volume. So never, ever, ever, regardless of any reason, flush the line. You never use a vehicle. If you're having issues with blood backing up into the line, you can consult pharmacy to potentially change the concentration so it infuses at a larger volume to help mitigate some of the backflow, but that's also why we have the backflow caps. You never stop the infusion unless ordered by the physician. If these medications are infusing peripherally, you have to have backup access. In case you lose the line or it infiltrates whatever for any reason, you need to make sure you have another access that you can switch over to as soon as possible. So you need to have backup access. At change of shift, it's part of your hamp procedure to make sure there's additional tubing, cap, batteries, coin, and CADD pump in the patient room. You're going to place the sign you see on the right-hand side outside the patient's room so that everyone's aware these medications are infusing within that room. These orange signs are laminated and can be found on the unit in a binder. And then you always want to make sure to leave the patient's door open at all times so that you're able to hear if the pump is alarming. Again, you heard earlier in the video the CADD pump alarm is not very loud. So if the door is completely shut, you may or may not hear the pump alarming. And again, if it's alarming, the medication isn't infusing. Patient pumps versus hospital pumps. So if a patient comes in and wishes to use their own CADD pumps, they may, as long as they provide 2 pumps, one that would be in use and one as backup. If they only have 1 pump, they must switch over to Kaiser pumps. We can't have them on their own as well as ours. It's an all or nothing type deal. They also must review and sign the agreement form that's in the back of the Epoprostenol IV infusion protocol. It's Appendix 2. And then when each nurse comes on, they should assess if the patient is physically and or mentally capable of managing their own pumps. If you don't feel they are, they must switch over to the KP pumps. Blood draws. So I put this slide in because one of the most frequent questions I get asked is regarding blood draws in patients with these medications infusing. So if you can, you are obviously going to stay away from where the medications are infusing by doing a venipuncture, drawing from a peripheral IV. Again, remember, these medications inhibit platelet aggregation, so if they do have peripheral access, they typically will draw back very nicely. But if for some reason or another you're unable to get blood work and they need it, and they have a multi-lumen access in which this medication is infusing, you can use one of the other ports to draw blood from. Again, this is a last resort and you still need to be very careful. You're still not going to draw from the lumen that has epoprostenol or triprostenol infusing. You're going to go to a different port. Wait till you hear the CADD pump deliver a dose. Again, the CADD pumps deliver in a pulsatile fashion. It's not continuous infusion like our Alaris pumps do with our other drips. So you wait till you hear the CADD pump deliver a dose, then you can draw your needed blood work and very carefully flush that line of the access site. Now I'm just going to review some of the highlights of the video and the key points. Again, the entire video is just to be used as a reference and hopefully a guide. Epoprostenol, half-life 3 to 5 minutes. Velitri and Flolan are both epoprostenol. Again, Velitri is stable for 24 hours at room temperature, and Flolan requires ice packs. For both of these medications, backup cassettes are kept in the refrigerator on the unit. The universal cassette change time is 11 a.m. Triprostenol, Remodulin. The half-life is 4 hours. Again, the universal cassette change time is 11 a.m. In this instance, though, backup cassettes of Remodulin are stored in pharmacy and they're ready on call. HAMP. All of these medications are high alert medications. Again, a double check is done when initiating the infusion, dose changes, cassette changes, line changes, and at change of shift. You also will do the DOT2RN check prostacyclin note that we reviewed earlier. Priming the line. You prime the line when you initiate the infusion, you change lines, or the concentration change is greater than 15,000 nanograms per ml. 80%. 80% of the dwell volume is your prime volume. And it's very important to remember to never flush the line, never use a vehicle, and never stop the infusion unless ordered by the physician. And always ask for help or clarification if you need it.